Thank you again. Again, I have no disclosures. So, I like trends. So again, trends in bariatric surgery, 30-day readmission rates. If you look over the last 7 years, whether it's the BOLD data, the ACS NISQIP data, or the MBSA QIP data, readmission rates overall haven't really changed. Gastric bypass is the most common surgery that gets readmitted, followed by sleeve and then band. Additionally, the etiology for the most common causes of readmission also have not changed. Whether it's the NISQIP 2012-2013 or the MBSA QIP 2014, it's nausea, vomiting, dehydration that always seems to rise to the top. So because of this, certainly this is part of the reason why we have these enhanced recovery programs. But interestingly, a meta-analysis done in 2017 demonstrated that ERAS in bariatric surgery does result in a significant reduction in length of stay and trends to reducing readmissions. It didn't have any effect on morbidity, major or minor complications. So you could read this as well. You know, these may be not as effective in terms of pathways, but more realistically, I think it just speaks to the low prevalence of major and minor complications that we have in our field, and that, you know, you can consider this sort of a phase in our field where we're fine-tuning things, which is really not a bad place to be. But the problem with ERAS protocols is that they can be really daunting, very difficult to implement. There's a lot of moving parts, and so it may prevent programs, small or large, from implementing things. So how can individual programs impact readmission rates related to nausea, vomiting, and dehydration? This is an algorithm, a simple algorithm that I use that I'll illustrate using our program, but essentially it's very basic. Just understand your specific program's quality outcomes and set your targets. Identify opportunities for improvement, and I would say start small. Know what resources are available to help you make those changes, implement a change, examine your outcomes, modify your program as needed, and then repeat. So this is what we did and do at OSU to manage nausea, vomiting, and dehydration. We basically started looking at this when we formalized our quality meetings in 2014, where we bring all our stakeholders to the table, which is pretty much anybody that touches our patient. And we reviewed our defined metrics and focused on areas of improvement. At that time, what we decided to focus on was readmissions, as well as specifically length of stay for sleeves. So when we tried to figure out reasons why we were having such poor outcomes, what came out in discussion was that there was prolonged nasal prong use. Our incentive spirometer was still, in the wrapping across the room. There was no consistent encouragement about getting the patients up and walking around, and there was a lack of consistent advice about oral intake. The basic consensus was that there was just variability in specific bariatric-related knowledge and experience among the nursing and the house staff. So to try to mitigate the variability, we created this care coaching program that we instituted in July of 2014. And essentially, at that time, it was for charge nurses that had bariatric nurse certification that were identified as having an interest in this patient population and volunteered for this role. On the day of their assignment, they were to educate patients and families about the daily plan of care from the time that the patient hit the floor to the time that they were discharged. They participated in daily rounds with the surgical team, and they called the patient after they were discharged on post-discharge day 1, 4, and 7. The education that they delivered included discussing the plan for IV and PO pain and nausea control, explaining the importance of incentive spirometry and showing them how to use it, encouraging ambulation, and then discharge planning, which not only included written material, but also a package that had a protein shaker, a pill crusher, 1-ounce medicine cups, and abdominal binders. They documented everything in a standardized flow sheet that just looks like this, that was embedded into the EMR, really just to improve the consistency of care between providers. And when we examined our results 1 year later, when we compared the care-coached patients to the control group, we found that there was less intractable nausea and vomiting in the care-coached group. There was a shorter length of stay, which interestingly translated to our sleeve population. We had improved HCAP scores with respect to nursing communication regarding medications, discharge information, and the likelihood of recommending our hospital. But unfortunately, there was no effect on our readmission rates, which was surprising and disappointing. So we drilled down on those readmission rates. It was about 6.6% for this cohort, which is better than the 14%, but the care coaching really didn't have an effect. But given that it had so many other positive effects, we just wanted to look at this a little bit more deeply. So we looked at the etiology of the readmissions, thinking, well, maybe the major causes for these readmissions just have no, or the care coaching program just wouldn't affect these. But the reality was that there was the most common cause for readmissions in our group, again, was not surprisingly nausea, vomiting, and dehydration. So then we looked at the timing of the readmissions. Was it that we were catching these in the wrong time, or they were coming in at a time when we weren't calling the patients? And you can see that the majority of the readmissions occurred less than or equal to 14 days, and that in fact, for nausea, vomiting, and dehydration, the median time was 7.5 days with an interquartile range of 4 to 16 days. So the readmissions were occurring at the time when our coaches were calling the patients on day 1, 4, and 7. So we still didn't understand what was going on. So what we did was then we drilled down even further and looked at the care coaching notes themselves. So taking into account that nausea, vomiting, and dehydration was about 36% of our readmissions, we looked at the notes. And we found that actually 50% of patients in this cohort suffered from nausea and vomiting that required IV hydration during their perioperative stay, and that 88% of the patients failed to actually meet their fluid targets at home. So how could we make changes here? So first of all, what we did is we changed our order sets to try to mitigate that perioperative nausea and vomiting. We changed our order sets to include additional antiemetics as a default. The reason being that when nurses want to administer medications, most of the times the residents are just too busy to actually put the order in. So to try to mitigate that delay in therapy, we just make it a default. Now, with respect to this 88% of patients that failed to meet their fluid targets at home, we reviewed what we did. We educate our patients before they leave the hospital. We give them the 60-60 rule, which is 60 fluid ounces of water, 60 grams of protein to make it easier for them to remember. We give them a mug to go home with. We tell them that we're going to reference that when we call them on these specific days. But we realized that each care coach had a different target for what was adequate fluid. So we standardized things. So what we decided was that someone who was severely under target was on track to drinking less than or equal to 30 fluid ounces over 24 hours. So when the care coach called them in the morning, they would give them until the end of the day to meet their targets, and if they didn't, bring them into clinic the next day. If they were moderately under target, then they were on track to maybe have less than or equal to 45 fluid ounces, and so the care coach again would reinforce the importance of fluid intake and follow-up phone calls more closely. And then finally, we actually changed the timing of the phone calls from day 1, 4, and 7 to 2, 4, and 7, because we realized that on post-op day or post-discharge day 1, patients are not even awake to get to receive the care coach's call. And in terms of how this has affected our program, we're actually analyzing that right now. So that was sort of the way, just an example of how we approach problems in the program. Certainly other things that we have done to decrease the poor PO intake and reducing readmissions is in the pre-op stage actually training our patients on how to drink. Typically we say, try to drink 1 ounce every 5 minutes. You'll get through 64 ounces in about 5.5 hours. You kind of make it manageable for patients. And if they do that, from the time they sign the consent to the time that they are in the operating room, they start to build that muscle memory, which makes it easier for them to recover perioperatively. We modified our care coaching program. We have whiteboards in the patient rooms so that they can have a visual reminder of what they have to accomplish. And aside from the mugs and the cups, our care coach actually created this little sheet where patients can actually cross off every ounce that they've drunk. So that it kind of engages the patient in a different way. And then, of course, we modified our discharge phone calls to the clinic, standardized the questions, and have earlier follow-up for fluid resuscitation if needed. And finally, and more recently, we have established an Idi Pathway, where we are flagging our bariatric patients in the EMR so that the providers understand, or recognize that these are bariatric patients. And once urgent reasons for readmission are ruled out, they now stay in a short stay unit for hydration. They're seen by the team, and are sent home, and we facilitate scheduling in our clinic as early as possible, which was pretty much clinic appointments are pretty much available every day of the week for our patients. So in summary then, ERS programs to decrease readmissions for non-urgent nausea, vomiting, and dehydration are very valuable, but they are really an algorithm of best practices. But one size doesn't fit all. So I would argue that for every program, just again, know your own outcomes, identify what you think is important to improve, know what resources are available, implement your changes, analyze your outcomes, make your changes, rinse and repeat. Thank you.